Right, everyone. Thank you so much for joining us today. Welcome to our webinar series. A little bit of details with Zoom is if you actually go in the upper right-hand corner of Zoom, there's a button called View, and you can go to the side-by-side speaker view, and that will allow you today to see side-by-side Dr. Beck's PowerPoint and then also his camera. You are muted and your camera is turned off. That is how it's supposed to be. But if you have any questions, feel free to raise your hand and I can unmute you. Or you can utilize the question and answer form and we can answer those questions for you that way as well. We'll answer as many questions as possible throughout the webinar. If we don't get to them, we can address them as well at the end. So feel free to ask as many questions as possible and we can address those as we need throughout the webinar. Our topic today, of course, is treating TMJ and craniofacial pain with oral appliances. Live attendees, make sure you stick around. There will be a promo code at the end. You also receive this in a recording following the PowerPoint or following the webinar today. So we have two speakers, primarily Dr. Beck, but also Frank will be chiming in here and there. So a little bit about Frank and True Function. He started True Function in 1999. He began as an RDA and has been working with the lab for over 30 years. 20 of those have been strictly sleep and TMJ. So Frank spent many years in research and development, creating workflows for True Function to create and digitize our appliances. So he's been a wealth of knowledge on all things oral appliances, working alongside clinicians as well to help with troubleshooting. So we also want to welcome Dr. Jim Beck. He's a dear friend of ours here at True Function. And Dr. Beck's aim is to provide the best possible care for our patients by consulting the latest scientific research in the field and using the most advanced technology. Dr. Jim Beck received his dental degree from Creighton University. Having practiced general dentistry for many years, Dr. Beck is now dedicating his treatments to patients with TMJ disorder and patients with snoring and mild to moderate sleep apnea who can't tolerate their CPAP machine. Dr. Beck is double board certified in treating both TMJ and sleep apnea, and he and his wife Jeanette started TMJ Sleep Colorado in 2011, and both have a passion for helping patients with unresolved craniofacial pain issues and sleep apnea conditions. He's a diplomat of the American Board of Craniofacial Pain, Cranial Dental Sleep Medicine, and the American Sleep and Breathing Association. He's a fellowship at the International College of Craniomandibular Orthopedics, as well as his fellowship of the American Academy of Craniofacial Pain. He works closely with bioresearch. Frank was his bioresearch trainer back in the day with electrodiagnostic mastership certification, and he's also a diplomat of the postgraduate education program there. He also is part of the Institute for Advanced TMJ Studies and mini residency. A few of the associations that he's part of is the International College of Craniomandibular Orthopedics, the American Academy of Craniofacial Pain, Sleep Medicine, Pain Management, and Cosmetic Dentistry. Dr. Beck is a Pueblo native and proud to have been helping his community for over 30 years. Dr. Beck is an avid golfer and an outdoorsman at heart, enjoying fishing and hunting when possible. He loves spending his time with his son, Tristan, and enjoying these activities together is very important to him. Dr. Beck has been working with Frank and True Function for over 20 years, so we're honored to have him to join us for our webinar series today. So Dr. Beck, over to you.
Thank you. Appreciate the information passed
You're
on. Want to start out by talking about Frank briefly. I have known him and worked with him and learned with him for over 20 years. I will say I've in 20 years had access to many different labs, and True Function is my go-to lab because of a few things. The work is always high quality. It's always received on the time that they told you it would be in your office. And I have numerous times reached out and had just conversations with Frank. I mean, literally 100 conversations, Frank. He is excited and interested in this field as I am. And so I definitely would recommend them. And I have had nothing but good things to say about them. Today's presentation, I'm going to be going pretty rapid because I've got an awful lot of information to cover in 1 hour. So they are going to provide the PowerPoint and the audio to this. So I would recommend go back when you get some time and listen to it and whatever. So basically, my objectives for today's presentation is two main things I'd like to accomplish. I'm going to show you the steps that we process a new patient all the way through starting treatment. And the thing that I'd like to see you glean from this is an opportunity to hopefully sell more cases. I really think that if you have a system in place, it can be very effective in terms of case presentation and case acceptance. And then at the end, I'm going to review the various appliances that I employ and go through specifics for when I use when and what. Okay, so I want to go to the next slide and my forward button's not. So just click right here. Okay, so disclaimer, I'm going to be speaking about TMD today, but in my practice, it's a lot of times hard to separate TMD and OSA in terms of certain chief complaints. I frequently get people referred to me for TMD, and then when I pull a few strings and do a little bit of examination, they actually have an underlying OSA, and vice versa. I get a lot of referrals for OSA, and inevitably they have TMD. So today's topic is going to focus on TMD, but my disclaimer is sometimes hard to separate the two. And let me adjust this. Can I pull this picture over a little bit so it doesn't cover up all the slide? There we go. So today's presentation is only a portion of the treatments that I do for TMD. Main focus being on the appliance therapy, but other things that we do, and it's unique to treatment and assessment, is we do physical therapy, laser treatments, cold laser, TENS therapy. I inject everything from the shoulder on up, and compounded ointment to mention a few areas that we treat TMD with. So the intake forms are pretty standard. I'm sure that there's nothing really overly special on the intake forms, although there is one part of the intake form that I think is huge, and that's the chief complaint form. The chief complaint form, and you're very welcome to copy and use in your office if you don't have something similar, is engineered so that the left column is all TMD chief complaints, and the right column is all associated with the OSA complaints. And what you want to do is go through that list on the left side and check your experience and/or / knowledge, because every single thing there typically has a root cause. Headache pain, depending on the headache pain location and whatnot, has a root cause. Ear pain, jaw pain, pain when you're chewing, facial pain, neck pain, noises in the joint, the congestion, dizziness, tinnitus. All of those typically have a cause. And the trick, I think, in treating TMD is through your examination and radiographs and whatnot, find that cause and figure out. And so on the right side is all OSA issues. And you give this to the patient, you're going to have them list in terms of priority their chief complaints. And that's a very important part of our processing of new patients. This is a patient that I'm just going to give you an example on, and basically 16-year-old girl came in, jaw pain, pain on chewing, jaw locking noises, headache pain, history of clenching and grinding. And how's it affecting your life? Yeah, it's hard to eat and I get headaches a lot. Results, I'd like to get the pain to go away. So I'm going to talk a little bit later on how I use this chief complaint information, because basically that's going to give us a door opening into the situation, but through interviewing the patient, I'm going to find a lot more information. So this is what starts the ball rolling in our practice. And then your fundamental medical histories is oftentimes going to give you some information. So from the minute they fill out their forms to the point that I do my clinical exam, I'm putting all the pieces of the puzzle together. So certainly, for example, if you look on the right side there, if they're seeing a chiropractor, I'm going to be wanting to, in my mind, figure out why. What are they seeing a chiropractor for? If they are seeing an ENT, why? So I'm putting the pieces of the puzzle so that when I get ready to give them a treatment consultation, I pretty much figured out what's causing their problems, and I pretty much have figured out how I'm going to help them. So again, I won't go through every single item, but you look at acid reflux. Sometimes people have acid reflux because of airway obstruction. Okay, well, we're talking about TMD. Well, airway obstruction has associated with it clenching. So, I mean, like I said earlier, it's often hard to separate the two. And again, the Epworth is set up for an assessment of evaluating OSA. But again, I want to get a feel of the whole picture of the patient so we could give him or her a comprehensive treatment. So I won't go too much into the systems. I'm sure you all have your intake forms to fill out, and they're probably very similar to what I'm using. So they have filled out their intake form. Now, the first thing that happens from that point is my son. He's the one there interviewing the patient in the ICAT. He's going to take an ICAT image, but he's also going to get a feel from the patient about their chief complaints. He's not going to look at it as in depth as I do, but he's going to start getting a feel for the patient, because this is part of the process. Everybody in my office is showing interest to that patient, and that's part of the process as far as eventually getting them to get case acceptance. So he's going to get a brief interview. He's going to take the image, and from there, we're going to look at some of the images of what I look at. So on the panel, what I'm going to be assessing of value is I am going to be obviously looking at the health of the gum and bone on the teeth, how many teeth they have available. I'm going to be looking at the measurement from the top of that condyle down to the gonial angle, because oftentimes the measurement's not the same, and it's very revealing on that. And so all of a sudden you could have a torque jaw because of a difference in measurement from the condyle to the gonial angle. I'm going to look at that antigonial notching, because when I see this sticking out there, and in many of my patients, it's extremely sticking out, I know that they have hyperactivity with their masseter, and that's a very diagnostic. So I'm getting a feel for that. I'm looking at the sinuses just to see, because a lot of times people think their headaches are from sinus issue. Well, this patient has clear sinuses. I'm looking at a gross look at the septum and the turbinates involved. So that's what I would glean from a pano. We always do corrected angle tomos from a sagittal and frontal view. And what's interesting on this particular tomo, look how much arthritis this 16-year-old gal has already. So that's pretty concerning. I'm going to talk about case presentation and appliances later on. To me, when I look at this person has distalized condyles. The picture's taken when they're in habitual occlusion. Her condyles are distalized. And then when I look at from a frontal view of the tomos, there's no space in there. So I'm already in my mind seeing someone that I feel are probably off of their disc when their teeth come together and or clenching. I look at the axial view of the angles of the tomals, and basically when you see a discrepancy of one angle 31.8 compared to 14, you basically have condyles that are not in harmony with each other. They're kind of symmetrically out of alignment, and that oftentimes is going to be a source of TMD issues. So we'll look at that. This Ceph is very revealing to me. I look at the straight forward head posture associated with this neck. There's no longer a lordotic curve there. And basically, when you have a forward head posture neck like that, you typically have either a TMD issue, typically a condyle that's distalized too much, and or a mouth breathing issue. So again, even though we're talking about TMD right now, I'm starting to look at the possibilities of OSA with this patient. We'll look at the sinuses, and basically you could see a little bit of a deviation of the paranasal sinus on the septum, and then enlarged turbinates. So I'm thinking, okay, here we've got possible breathing issues. And even though it's not definitive, there's definitely a airway space deficiency on this particular patient. And this is an axial view. So there's definitely possible airway breathing obstruction here. So now what happens here is my son is going to pass the baton to me, and he's basically going to be revealing the information that the patient has filled out. So he's going to kind of give it the information that from his interview to me. Now, this is really important because I'm sure all of you have been to doctor's offices and you fill out 3 pages of information, and then it's almost like no one's even read it or heard it. And it's like, why did I fill that all out? And so we don't do that. We want people to know that we have duplicated the information that they have sent to us by filling out their form. So he's passing the information. He'll give other information like patient's pulse, blood pressure, Epworth score. And so then I'm going to now talk to the patient and interview the patient. This is a key part of how I treat, because I'm going to get a feel of many things. And so basically, I'm going to ask many questions. And in particular, she mentioned she has jaw pain. So I'm going to say, okay, show me with your finger where your jaw pain's at. Because a lot of times people don't know where a TMJ is located. All they know is their jaw hurts. And so they'll point possibly to their masseter, okay? And then I'll ask them, how long have you had that jaw pain? What makes it better? What makes it worse? Specifically honing in so I could get a feel of the pieces of the puzzle here. So I will go through all of their chief complaints, and I will ask them, is it right-sided, left-sided, both sides? Day or night? When does it occur? What makes it better? What makes it worse? And by the time I've done that and looking at the x-rays, I could almost tell what I'm going to need to do on this patient without even doing a clinical exam, okay? Because I've seen and done so many people that they have a very consistent pattern. But at that point, once I've interviewed them, and then I ask them, is there anything else you want me to know? I've gained information, but I've also established a really good relationship with the patient. By then, they're really feeling comfortable at being in an office that cares and being in an office that listens. And ultimately, once the interview's done, I'm going to start doing a clinical physical exam on her. But something I learned many years ago, I've been treating TMD probably for over 25 years now. One of my mentors always told me that the mystery of the problem is in the history. And so that stuck with me. I'm sure, Frank, you remember hearing that back in the day. So this is my exam setup. I'm going to need to figure out range of motion. I'm going to use this Bully gauge to measure the Shimbashi of people, very key diagnostic part of my protocol. I look inside the nose to evaluate the turbinates and basically a little ruler. Okay, so that's my exam setup. And some of the highlights of my exam is I'm going to measure the range of motion, including lateral excursions and protrusion. I'm going to measure overjet over bite. I want to see where the skeletal and dental midlines are, so I assess that. Again, to rule in or rule out possible OSA, I'm going to look at that palate, tongue level, malampati. I'm going to look and assess tonsils. And one of the most important part of the clinical exam is muscle palpation. I cannot emphasize enough how important expert muscle palpation is. And I'm talking about key elevator muscles, your temporalis, your masseters, your medial pterygoids, your lateral pterygoids, knowing and understanding intimately the origin and insertion of these muscles, because in doing a comprehensive muscle palpation, including the TMJ, I'm going to really get a feel of where this patient's at. But equally important, the patient's going to start realizing the issues that they have. They're going to start taking ownership in pain issues that they may not know, because a lot of these people have pain, but they really haven't processed it. I mean, the brain can only process so many sources of pain at one time. And by going through a comprehensive examination and palpation, it's going to be feeding into my consultation, which comes down the road here. So very important to become professional and expert at muscle palpation. These are my go-to appliances. I'm going to, at the end of this presentation, go through each item, each appliance individually and show when and where I use them. But basically, a day demand comes in two forms: the milled one or the traditional one. And basically, we call this a joint stabilization device. It was previously called a clenching device. We also use a FARA appliance, a nighttime deprogrammer, and just a common L6. So those are my go-to appliances. So now I'm going to talk to you about consultation for a patient. And the whole process is to spend enough time with them so that they could understand why they have a problem, and then ultimately what I'm going to do with understanding why, how we're going to fix it. Okay, so the things I'm going to show you are pretty important to have when you're giving a case presentation to patients. So we're going to start out with the skull, and basically it's going to open the door to their understanding about basic fundamental TMJ anatomy and function. So we're going to take a skull with a jaw joint, and we're going to emphasize this condylar position, because this is a key focus that I have in my practice. Okay, this is from my education and training and treatment on patients, a correct condylar position. And I know there's different camps on that, but this is where I treat from as far as a correct functional position. And we're going to show the patient that the condyle is in his anterior position. We're going to show that there's spacing with a disc in place. And we're going to just kind of show the patient what happens on opening and ultimately translation of the condyle. I have this here available. Again, this is more on the area of OSA, but I'm going to be showing a patient the side sagittal view of the nose. We're going to show them the uvula, tonsils. We're going to show them the tongue, and basically show them what a normal airway space is. And so that's, again, like a golf club in my golf bag. I mean, you have to kind of identify where you're going to go with the treatment, so then ultimately you have the devices that's going to help present information so the patient accepts treatment. So primarily used to discuss the airway, the tongue. I do emphasize when I'm talking about OSA treatment to a patient that the tongue is fundamentally attached to the lower jaw, and the lower jaw's position is controlled by the way the teeth come together. So then obviously you could develop, if you are doing OSA treatment, how moving the jaw can affect pulling the tongue out of the airway, and ultimately how this is a effective way to treat OSA. We're going to talk about something that's normal. I will tell you situationally, depending on the patient, I will take them back to my x-ray room and I will go over their x-rays with them, and basically when I do that and when I don't do that, because I don't do it on every patient, is I'm looking at the patient as I'm giving them information, and I'm identifying the indicators they're giving me, if they're tracking. So I don't want to overkill them with information. I just want to give them enough information so that ultimately we can move forward with treatment. So we're going to talk about nose, uvula, tonsil considerations off of this particular sagittal. It's a plastic sagittal skull. Demonstrate OSA with it. So this is a device that's in my my toolbox. When I start talking about the TMJ in particular, I'm going to show them the TMJ on the skull, and then I'm going to show them this slide. And what I'm basically going to emphasize is a normal jaw joint has a cushioning in between the condyle and the fossa, ear being over here. The back part of the socket is loaded with nerves and arteries. I'm gonna ad nauseum almost tell people where this condyle should be postured, because it's a key paradigm that they need to understand. And I'm going to let them understand that if this condyle is distalized, among many things, it's going to be putting pressure on nerve and arteries. So basically, this is a handout that I have that is very relevant when I discuss and inform the patient. This is a key part of the presentation because it talks about stages of internal derangement. And basically, it shows how a jaw progresses from normal to having stretched ligaments where the disc starts slipping off. This is stage 1, to advanced stage 2, where the disc is completely off, stage 3, where the disc is locked, and then ultimately arthritis. So again, I'm giving this information with the idea of ultimately telling the patient, this is where you're at with this, with your situation. So they could then take an understanding and ownership of what their particular jaw situation is going through. So important to go through each stage as needed. If a patient doesn't have arthritis, I don't go that far along. Typically they'll fall in a stage 2 area. Okay, so they need to understand what stage they're in. This is a very valuable handout because, again, it can show that if a condyle is distalized because the disc has popped out of place, how now all of a sudden chewing forces, clenching forces are now pinching on nerves and blood vessels that literally innervate the whole head and face and neck. When the condyle is distalized like this, it's right on top of the ear. So many of the ear problems that people have is from inflammation in the jaw that's pushing into the ear. So a very valuable aid in educating them what's going on. So very important to illustrate problems of the condyle, how close the proximity is when this condyle distalizes to an ear, and discuss the consequences of a displaced disc. If you don't have a TMJ tutor, you absolutely need to order one if you want to sell TMD appliances to your patient. And I don't like to use sell, but if you want to educate patients so that they'll accept your treatment, this is basically indispensable in my practice. This particular position where the teeth come together is basically a normal condyle with a disc in place. You can adjust this so you could posteriorize the condyle and basically very important to illustrate untreated TMJ function, because if you have this condyle and disc off of the condyle where the condyles distalize, you could illustrate how opening will now cause the disc to pop on. That's when the people get their, oh, I get it at the moment, or my, I understand why my joint's clicking now. So ultimately, if I'm showing this and I have a displaced condyle, displaced disc, my go-to appliance is going to be a Data-Mand or a Mora, mandibular orthopedic repositioning appliance. And the beauty of this TMJ tutor is it shows how by changing the bite, you could actually change the function of the jaw joint. And that's one of, as I developed a Data-Mand at the end of the presentation, that's a key reason why I use a Data-Mand appliance. Okay, so this is a very valuable aid in patient education. And this is a trigger point pain referral chart that's indispensable in my practice. And so, for example, the X's are where trigger points are in a muscle, and the red is the referral patterns. And so going back to the interview of the patient, if I am interviewing them and oftentimes they'll indicate that they have headaches, I'll ask them, okay, where's your headache at? And a lot of times they'll say it's at the back of my head, and then it moves forward. Well, knowing intimately that if the SCM has trigger points in it, it's going to refer pain to the back of the head. I start putting the pieces together. Okay, what would cause forward head posture? Well, we mentioned earlier in the presentation, a dysfunctional jaw joint is going to cause forward head posture. Mouth breathing could cause forward head posture. So now all of a sudden, again, pieces of the puzzle, okay? Also, you notice that the SCM can cause ear pain, okay? Or a lot of times people say they have headaches in the front of their head. That SCM is very relevant to a TMJ problem patient. This here shows masseters, and a trigger point in a masseter can ultimately cause ear pain or ear issues. So again, another one of my tools in the process of the patient. So head neck trigger point, extremely valuable in discussing trigger points or myalgia and referral patterns. The goal of the consult is to explain why they have the pain and how the appliance is going to help them. So basically, once I've went over with the patient, given them understanding of why they have pain, what I'm going to do to fix it, then I'll pass the baton back to my son, who is going to be giving the patient a consult. Now, as Trish alluded to at the beginning, I don't do dentistry. All I treat is TMD and OSA. We're in network with all insurance companies. And basically, at this point, we know what the insurance coverage is for the patient, and we're going to give them a financial consult. If they accept treatment, then we're going to go right to that day. We schedule an hour for our new patient experience, and the whole objective is in that hour's time, we've examined them, diagnosed them, giving them financial consult, and we're going to start treatment that day. And so that's the protocol we follow in our practice. So this is just showing me doing a bite registration for this particular patient. I'm basically showing a picture of doing a phonetic bite registration. And if you want to earn a little extra income, you can learn to make appliances for your dogs or patients' dogs. So here we are scanning the teeth and getting ready to take care of our dog with a day demand. Just kidding. So here we're going to, once we do a bite registration, we're going to scan the teeth. We're going to create our lab script. And now we're going to talk about a summary of the different appliances and when and why I use them. So the first appliance I'm going to talk about is the day demand. And I don't know if Trish's thing is blocking the pictures of the appliances here or not.
For you, they are, but everyone else.
Okay, so I assume everybody can see it. So the meal day demand and the traditional day demand both accomplish the same thing. They're designed when a person has intracapsular problems. We figured out that they have intracapsular problems because through my interview, if they've indicated that they have chief complaints of a jaw problem, and then I in fact asked them to point on it, and they're pointing right at their TMJ, along with me palpation of the TMJ and my radiographic evidence, I can diagnose that they have an intracapsular problem. So the day demand is going to realign their bite and consequently realign their jaw joint. And so it's engineered to capture a disc and posture the condyle and the faucet a correct functioning position. Oftentimes people's discs are stretched so far out of place that they're not always going to capture the disc. The more chronic the TMJ problem, the less likely that you're going to actually capture a disc. But it's still going to realign the condyle to function from a correct position. And it's going to realign the jaw from a three-dimensional relationship. It's not just a vertical or anterior position. It's a realigning of what we used to talk about, pitch, roll, and yaw of the jaw joint. So very important functional appliance. I say that because in addition to opening up the vertical, and I talked about earlier in my examination, I assess and measure what we call a Shimbashi measurement. Typically, a Shimbashi measurement, which is measured from the CEJ of the upper central incisor, CEJ of the lower, should be in the range of 17 millimeters plus or minus a millimeter. Oftentimes, you'll find your TMJ patients are overclosed vertically, and it's not uncommon to have a Shimbashi measurement of 12, 13 millimeters. So the day demand is going to, by design, open the vertical, and it's going to move the mandible anteriorly. And most important, this is a functioning appliance. And this is where you need to explain to the patient that they have to wear this appliance and they have to eat with it. It's an appliance they wear all the time during the day, and it's going to earmark towards correcting dysfunctional TMJs. And by the nature of it, typically at the end of phase 1 treatment, where I've resolved the chief complaints as good as I can possibly get them, they're going to be at a crossroad, because at that point in time, we give the patient an option to wean off of the patient. Remember, you're wearing this appliance all the time during the day and eating with it. And we give them an opportunity to gradually wean off. But some people, when they start gradually weaning off, have their symptoms gradually come back. At that point in time, they're going to have a discussion about phase 2. And typically phase 2, back in the day, if the people had really bad teeth, it would be full mouth rehabs that I used to do quite frequently, or orthodontics, which I did frequently, or some people end up just staying in an appliance indefinitely. I mean, I get people that are 65 years old that have TMD issues, and they're not really ready to do a full mouth rehab, and they're really not interested in ortho, so they just live with the day demand, and then we keep them on a regular evaluation and replace it when it wears out. So that's my day demand appliance.
Doctor, if I may interject on the day appliance real
Sure.
quick. Just a quick note for requirements from the lab's perspective. We do ask for a maxillary mandibular scan or impression. And then, as Dr. Beck mentioned, I know you take a phonetic bite. So a treatment position, super important. The lab, should not make an appliance from a CO for this type of device. Bite probably won't be right for your patient. So the extremely important that you take a treatment position bite.
Yeah, and I mean, I only have an hour to talk today, and so I'd love to go over my techniques of bite registration, but that might be a different presentation. But can you show me how to go back to a previous slide? Okay, so on the 2-day demands, the only thing I would give you information to understand is the milled appliance covers the lower anterior teeth. If you have a particular patient who doesn't want it to show in their mouth, then that's where I go to the tradition, because it does not cover the lower anteriors. And basically, oftentimes when I give Frank the bite registration, there's typically a gap in the front of the teeth. I mean, so the people are going to have to learn that this is not like teeth chewing. I mean, you're going to learn and get used to chewing with differently than what you're accustomed to. And you're not going to be able to cut things off in the front with a traditional appliance, because there's typically a little gap from the vertical opening that's necessary. So, I kind of give them a decision point as far as the milled one, which will fill in some of the space in the front, versus the traditional, which does not. But that's the two main considerations on that. So my next appliance is called a joint stabilization device. We used to call it back in the day a clenching appliance, but we changed that name, and it basically has to do with the intricacies of billing medical insurance. But it's basically a anti-clenching appliance. It's very conservative. We make an awful lot of these. It's very non-invasive. Capsulitis is inflammation in the jaw joint. Myalgia is pain in the muscles. So it's my go-to appliance to deal with those issues. It's not as invasive as a day demand, because basically they're going to wear this appliance. I typically have them wear it 24 hours, 7 days a week for the first month, but they get to take it out and chew with their own teeth. So the appliance is designed to take away the adverse forces associated with muscle clenching. And it's not just clenching muscles, because back to what I was talking about, pitch, roll, and yaw, if the teeth are not in harmony with the muscles in the jaw joint, you're going to establish very sore elevator muscles. Okay, when you go back to the anatomy, your temporalis is a jaw posturing muscle, and oftentimes people, if they've got missing teeth or teeth that have what I call a roller coaster bite, where they've got a ton of dental restorations, bicuspid drop off, decreased curvus feet, these muscles are going to be very, very sore. And that's where I went back to what I was talking about. Become expert on a muscle palpation part of your exam, because you'll expose and find those sore muscles. But anyway, long story to make the point that the joint stabilization devices that allow these muscles to recuperate and allow them to heal. I always tell people familiar with exercise, and if you do a lot of exercising, ideally you get a chance for your muscles to recover, you get nutrition and rest. And what typically is happening with these people with adverse muscle trigger points, muscles never get a chance to rest. They're constantly sore, and then pretty soon they start breaking down. So this appliance is very effective, but very easy and conservative to use. It will also decompress the TMJ because of the nature of the design of the pivot in the front. It's going to decompress that jaw joint, and it's going to allow that capsulitis to dissipate. And the way it's working is it's similar to an NTI, but better, because the lower anterior are going to be the only thing that occludes with the discluding element up front. But unlike an NTI, it's covering from lateral to lateral. And basically, I will, with this device, take the posterior teeth out of occlusion, and you literally are going to now allow the muscles to rehab. The downside of many of the appliances, the patient will come in where the dentist has made them a night guard, is the night guard is something that's going to protect teeth, but it's not going to help jaw joints and muscles, because they can clench and grind like crazy on a night guard. And they'll come in with a history of it. They'll normally wear through one, or they'll have a history of having bought one at the store, and it's made their TMJ issues worse, or muscles worse. Typically, I will make this in conjunction with also having a lower Essex made. And the idea of the lower Essex, which we're going to talk about that a little bit down the road, but it's to basically, when they're sleeping at night, wear two appliances. The upper, you're going to have your joint stabilization device. The lower, you're going to have a lower Essex. And that's going to protect the forces that are going to be put on those lower teeth. Oftentimes, if they're really powerful clenchers, at nighttime, they'll put excess force on those lower anteriors, and the patient will come back with issues with that. So the Essex appliance is basically a suck down for the lowers, similar to an ortho retainer or a bleaching tray. Primarily used in conjunction with the joint stabilization device, the nighttime deprogrammer, which I'm going to talk about here shortly, and the FARA appliance. So again, at nighttime, I'll have people wearing two appliances. And the Essex will protect the lower anteriors from excessive forces. Worn primarily at night. Now, having said that, if you remember back when I was talking about the joint stabilization device, is that what you call it on your lab script nowadays, Frank? JSD or?
So we call it a anti-clenching / JSD, joint stabilization. So yeah, I believe we have a combination of the two.
Okay, so I tell them to wear this every night along with the JSD, but some people are daytime clenchers. And if you remember, I told the patient for instructions, for the first month, I want you to wear that day and night, except when you're eating, then you take it out. If a patient is a daytime clencher and they cannot control it, which some cannot, it's just such a habit, and even though they want to stop clenching, they can't, then I'll have them wear that Essex during the day also. So it's based on the patient's particular situation. A nighttime deprogrammer is just basically a JSD, but it's more durable. Okay, so everything that I indicated for the JSD, joint stabilization, is why I do a nighttime deprogrammer used for the same indication as the JSD, primarily worn at night, and it's more durable. That's the key feature over the JSD, because some of these powerful clenchers can break a JSD. So it's just basically going to give them more bang for the buck as far as how long they wear. And you'll find these people coming back, and they've worn notches in these discluding elements. This is the anterior parts of the discluding element. But again, go back to my disclaimer, because have you ruled out obstructive sleep apnea? You know, I mean, because that's something to be very informed about, because you could be treating a TMD issue that has underlying OSA. So be aware of that.
Can I interrupt you for one moment for a question?
Sure.
With no posterior support, do you worry about the NTI and the stabilization will worsen the overloading and posteriorization of the TMJ and condyles?
Say that again a little slower.
With no posterior support, do you worry about the NTI and stabilization will worsen the overloading and posteriorization of the TMJ and condyles?
I don't use an NTI, first of all, but basically I don't personally see that. Okay. I've heard of that, but again, I also see it's a good question because I see my patients once I've started TMD treatment on them every 3 months, and then sometimes if they're MMI longer than that, I'll put them on 6 months. But I've heard of having that issue. I haven't seen that in my patients, and basically by keeping an eval every 3 months, I ensure that doesn't happen. But typically, if that condyle rotates posteriorly, you're going to get some issues with the posteriorized or distalized condyle. And one thing that I also want to talk about on this is the JSD is a starting point, least invasive treatment. And basically we will do that, and then we will reassess the chief complaints in 1 month. And depending on how well they improve or not, I have then options to use the therapeutics. But ultimately, I do have to graduate a patient into a day demand. But again, I try to do the least amount to get the results achieved, and then add on as I need. A day demand is a more invasive commitment to people, and typically I don't do that unless again I have the intracapsular issues. So again, the nighttime deprogram is used in conjunction with the lower Essex also. A FARA appliance is used primarily when I have to unlock a patient. And what I typically will do is first of all, diagnose that they are locked. So most of my unlockings are preceded with an MRI. I unlock them. Now, it's not really discussed as an appliance, but it is an appliance. The day that I unlock people, I will use thermal beads to make a temporary appliance. And so we're going to put that unlocked patient in an end-to-end position with the thermal beads. And then we're going to have them come back at a later point, typically a week or so later. And then we will take a bite registration and make a day demand then. So they have to go through a transitional temporary period of being unlocked. And the bead appliance that I make at an end-to-end position is worn 24/7. The only time they take it out is to brush their teeth, and they put it back in. And that's just to prevent them from going back and being locked. But the point being is once I go into now a permanent appliance, that's when I will use the day demand, and then I will make a nighttime appliance with the palatal ramp or the FARA. And so basically the FARA is going to hold the jaw in the same identical position that I made the day demand to. So this is a nighttime appliance in the event that I've unlocked someone and we want to basically use the appliance at nighttime. So it's used in conjunction with the day demand. Now, I have used this appliance as a non-titratable OSA appliance. And basically under the right circumstances, it actually has worked. I just had a patient the other day, had a very tiny mouth and very limited tongue space. And I made her a traditional appliance, and quite frankly, the appliance didn't work because she had even less tongue space with the OSA appliance. And so basically, this will hold the jaw position because of that palatal ramp. And typically I will have them put a hole right there so they could actually have their tongue go in that little hole space. But I've actually improved OSA situations by using this FAR appliance. So that's kind of a pleasant little discovery for me and the patient. And it also is designed to function like a nighttime deprogrammer, because this anterior discluding element is going to create posterior disclusion. So at this point in time, I am done with my presentation. Frank, I don't know if you wanted to comment on your promo, or Trish.
Yeah, I'll take over from here. I do have a couple questions too that if we could answer those for a moment, and then any follow-up questions we can answer after this slide. But Dr. Nagar, I'm going to allow you to talk. I'm going to unmute you if you want to go ahead and unmute yourself and ask Doctor your question. Okay, while he's getting that situated, the other question was, with a closed lock, will you do injection to try to unlock before placing the Farrar?
Yeah, again, there's so many topics that I would need more time to, but I pretty much unlock 90% of the time by using an injection. It creates hydrostatic pressure. And again, the FARA has to be made after you've scanned the teeth. And oftentimes when they're locked, they don't have enough range of motion to scan them at that point. So that's why I actually have to unlock them, put an immediate appliance in their mouth. It's a in-office made appliance. And then I have them come back so that I could then, with an improved range of motion from being unlocked, then order a data man and a FAR appliance. So that's typically the protocol I follow.
Awesome. All right. I know there's a few other questions. We'll get to those in just a moment. I'm a little bit.
I got to plug my computer in. It's going to die on me here.
Okay. Yeah, you plug that in while I take over here. Thank you everyone for, of course, joining us this evening. If you have any questions on the lab specifically, or getting set up to send us those appliances that he discussed, I did put the new account form in the chat. The promo code that is on the screen is 20% off any milled full coverage day and milled Farrars until September 8th. So go ahead and use that promo code on anything that you send in. If we receive those before September 8th, you'll receive the 20% off discount. So invite you to join us also on social media, because we'll post tech tips, our new webinars that are coming up every month in our webinar series, and any specials we're running there. So it's a great way to keep up with True Function, both on Instagram, Facebook, and LinkedIn. Our next webinar is going to be featuring Dr. Correa with Tufts University. He'll talk about the management of snoring and sleep apnea with oral appliance therapy. So that's on Wednesday, August 30th, and I will also go ahead and put that in the chat. If you want to register for that today. I hope you'll joining us. I will, of course, as well, send you over the recording. So give us about a day or so and we'll get that recording to you. Feel free as well to put in the chat any other topics you may want discussed, or if there's anything Dr. Beck didn't discuss that you would love him to come back on for, feel free to put that in the chat. We'll take that into consideration for continuing our series. So thank you everyone for joining us, and we'll open it up now for more questions. Now, Dr. Beck, the next question is, hi Angela, good to see you. She asked, do you work with an orofacial myofunctional therapist in conjunction with oral appliance therapy?
I have in the past. Right now, I don't have anybody. They're hard to find. But yes, I have in the past. Okay.
The next question is there ever any indication for a flat plane splint?
You know, that's a good question. So yeah, one of the things that's hard to find is functional orthodontists. And basically a functional orthodontist, in my description, is someone who can take a TMJ patient who's reached maximal medical improvement at a new position by the data man. And so then what has to happen is then you have to have an orthodontist who's able to pull the teeth together to replace the appliance. And so what we will do, because I do have an orthodontist, is if a person has been wearing a Data-Man, and I'm going to guesstimate for 3 months or longer, their jaw is now programmed and their muscles are now programmed on a trajectory that is not going to change. And so what I will do with the patient is I will change my Data-Man into a flat plane to answer your question. So what I will do is I will have them tap into the appliance, and all I will do, I'll remove all the anatomy. I'll turn it into a flat plane, and I'll remove all the anatomy except the palatal cusp contact, so the upper arch palatal cusp contact. All right, so now what typically happens is that trajectory is not going to change because it's now been programmed into the jaw and the muscles. The orthodontist could then develop the upper arch, and as they develop it, they send them back to me, and I'll make equilibrations on the flat plane now because it was previously a Data-Man. And so that, in my practice, is the typical use of the flat plane.
Okay, the next question is, so if a patient has both TMD symptoms and OSA, you go with OSA appliance first?
Great question. Yeah, because obviously on the order of priority, breathing and living is more important than pain. But oftentimes, a lot of the reasons they have pain is because of the inadequacies of the breathing. But what I do in my practice is I will make them an OSA appliance and a JSD, because what I find frequently is I'll give them appliance, and my protocol with this OSA appliance is I'll insert it and I'll have them come back in 2 weeks. Well, if you have a patient who you've diagnosed with TMD issues, basically sticking that appliance in the OSA appliance at night is going to create TMD issues. It's going to stir it up that's already underlying there. Okay, and so oftentimes they'll wear the appliance and then they'll wake up and they'll have pain in their jaws and their condyles and masseters or whatnot. And so I have to kind of manage both of them. So what I will do is I always tell people when I insert the appliance, and especially I could anticipate from the exam, the ones that are going to start using that OSA appliance and start getting TMD issues initially, is I will tell them, okay, I'll give them exercises to stretch. You wake up in the morning, your facial muscles are sore. I give them 3 stretching exercises. I also, on that topic, I will have made them a morning positioner, okay? Because a lot of times these people, when they start wearing these OSA appliances, their jaw's going to want to start moving forward and stay forward. And so we'll make them a morning position to prevent that. But I also will make them a JSD. And I give them explicit instructions. If you have pain the second night, when you're ready to go to bed and put that OSA appliance in there, don't wear the OSA appliance. Take a night off. Put the JSD in there. And so what happens is if you have a TMD issue and a OSA issue, I'm going to treat the OSA, but I'm also during the daytime going to treat the TMD. Okay, and the conservative treatment is a JSD appliance. Then I have other things, as I mentioned earlier, you know, that may be part of the TMD treatment. So yeah, always prioritize. OSA is more important than TMD. Oftentimes, correcting the airway will help the TMD, but also be prepared if you've got an underlying diagnosed TMD condition that it's not going to just be a bed of roses with that OSA appliance.
All right, just a couple more. How do you verify the phonetic bite prior to sending it to the lab? And frankly,
Well,
it might be a little bit of both for both of you.
No, what I do is I've got my initial cone beam X-ray machine, and I really believe you can't really treat TMD and OSA if you don't have a iCAD or a cone beam. And so I have my initial habitual bite condyle posture. I will then take a phonetic bite, and then I will take another quick scan to assess the condylar changes. And from that, if I don't like the changes, oftentimes I will communicate with Frank, okay, retrude that bite I sent you 1 millimeter, or rotate it 1 millimeter to the left. And so that's how I confirm my phonetic position.
All right, one more. Do you see more TMD issues on the left side of women with TMJ?
Actually, I see, if I recall right, and that's a good question, but it seems like I see more on the right side. But I couldn't confirm. But typically, you will have a predominant one side versus the other. And then what's ironic on that is when you look at the tomos, the chief complaints, for example, may be all right-sided, but when you look at the X-ray, the left-sided condyle is in worse shape, you know, and it's an interesting thing. But I couldn't really honestly say I've seen more right or left. It seems like I see more right-sided, but I haven't really taken numbers on that.
All right. Well, that is the end of the questions in the question box. Does anyone else have any other questions?
Just a quick comment on my end, Dr. Beck. Thank you so much for joining us today. You modified your plans for us, and we appreciate that. And I wanted to thank you again for over 20 years of support. We got through a lot of stuff together, and we're blessed to work with you. And you are much appreciated for your knowledge. Everything you taught us, taught me, and also for spending your evening with us today. So thank you.
Well, thank you, Frank. And I would like to kind of comment back at you, because what I like about our relationship is we're both very honest, and we both are very realistic, that we're not mistake free. I've made mistakes, you've made mistakes, and to have a working relationship where there's this tolerance and not beat someone into the ground for making a mistake is just totally refreshing. And I will say, you're a very stand-up guy, and I really have seen over time, if there's issues on your end of it, you make it right. And I think you could probably say the same thing with me.
Absolutely, yes.
And it's totally refreshing to have that, because you don't find that in a lot of people, so I value our relationship.
Thank you, Doc. Thanks for your support, and wonderful. Well, again, we appreciate you, and this was a great afternoon to spend with you. So everyone, thank you for joining us. Trish, did you just want to?
Yep. Yeah. Thank you everyone again for joining us. Just one more quick reminder. The specials are on the screen here for the milled appliances. If you want to take advantage of those through the 8th, we have that next webinar coming up the 30th of next month, all on sleep apnea with Dr. Correa from Tufts University. So the link to register for that is in the chat. If you want to work with TrueFunction and you haven't before and you want us to contact you, feel free to click that new account link that's in the chat, and we can connect with you. We'll reach out to you as soon as you fill out that form, and get you started and walk you through getting those appliances to your patients. So feel free to stay in touch. If you have any follow-up questions from here moving forward, feel free to email us, reply to that confirmation email, and we can get those answered and communicate with Dr. Beck. Otherwise, we look forward to seeing you next month for our next webinar.
Thank you all. Thanks again, Dr.
Thank you,
Beck.
Dr. Beck.
Thank you, Trish.
Frank. See you, Trish.
Thanks, Dr. Beck. Have a wonderful trip.
You too. Talk to you later. Come and join.
Okay.
All right. How do I turn this off?